Hello. Hi, everyone. Welcome. Welcome. My name is Brian Scarpelli, and I'm the Executive Director of the Connected Health Initiative. On behalf of the Connected Health Initiative and its members from across the digital healthcare ecosystem, thanks for joining us today for this exciting webinar, Venture Capital Digital Health Startup Experiences and Perspectives. Just as a little bit of background, the Connected Health Initiative is a not-for-profit advocacy effort that on trying to advance helpful pro digital health policy changes throughout federal, state, and other layers of government regulation. It's The Connected Health Initiative is driven by the consensus that we identify across a wide range of stakeholders that populate what we call a steering committee, that ranges from small developers, larger developers, providers of all different shapes and sizes, serving urban and rural and suburban populations, payers, clinicians, et cetera. And so, as you know, we're constantly identifying where are the threads of agreement that run across all those different communities on digital health policy that can enable the responsible development and deployment of these technologies that will advance the quadruple aim: improving patient outcomes, reducing costs, augmenting population health management, and supporting the healthcare workforce. All those are super important to us. So enough about the Connected Health Initiative. Um, I guess we're sort of here today. We're here today. We get a lot of questions from out there in the ecosystem in the real world. Basically asking, how do investors and advisors actually think about this space these days, and as things evolve, and what does, for example, an early stage digital health company need to look like to attract capital, to attract the right talent, to survive long enough to reach their exit goal. And today, fortunately, we have three people who are true experts on all these issues, but who come at this from some different angles. So in for just I'll briefly introduce our speakers real quick, just to preview the agenda. Just their name and title, and I'll let them describe when we start talking. A little bit about themselves and their background and what they're working on. And I certainly have a good number of questions to have us kind of going a little bit of a sequence for our discussion. But I really welcome everybody to bring your questions, which you can use the Q&A feature in Zoom to do, or you can send a chat. I'll look at both of those. But you know, uh, uh, first, I'll just briefly mention our speakers. So first is Stephen Fortes, managing partner at Fresco Capital. Then we have Jonathan Suckling, director of programs and strategy at the Center for Aging and Brain Health Innovation, or CABI. He's in Toronto, and then Robert Jaron with the Omega Concern, who's an advisor to a wide range of businesses on coverage and coding and other digital health challenges and issues. So I have some opening questions, kind of at least one for each of our speakers. But why don't I just jump right into it then? Maybe Stephen, if I could go to you first. First, that maybe tell us a little bit about yourself, but from your experience, when a digital health founder walks into a meeting with you in 2026, what are the things you're actually trying to figure out in the first 10 minutes? And what are the things that maybe you see these founders thinking about that they think matters, that might actually not be so important? Any other sort of uh, reactions you might have to that kind of high level question is great.
Sure. And just to give a little more perspective, is we're early stage VC fund. What we do, we invest across the stack. But just for the perspective, is we invest in other categories as well, but we do have a specific digital health fund, and digital health is different. We do look for different qualities of a founder. We look for different metrics of a company that we're looking at. So compared to maybe some of the other domains that we invest in, let's say, B2B SaaS and things like that. So that is an interesting category. So digital health is one of the categories. As I said, we have a fund very specific to digital health, predominantly in the United States, which I guess is relevant here, but we are a global fund. So I do get a lot of digital health that comes from Asia because I have partners in Asia, and we make very few digital health investments outside of the United States, but we have. So with that kind of preamble, um, what we look for in the fund is specifically a ability to penetrate a larger market to generate some growth. Because at an early stage, a founder is looking to establish their addressable market, right? So do you have a product or a service that is going to have some type of proverbial founder product market fit? That is kind of table stakes these days. But more importantly, is the do you have the ability then to grow into a large market size? That is the magic. And then the second part, Brian, I think that is most important is a lot of people come to me and say, because we invest in, kind of two stages. Sometimes we don't go super, super early like that, like accelerator early. We tend to be like in that in between, like your seed and series A. So a lot of people will come to us and say, what do we need to get to like that next level? And a lot of people will think, a lot of founders will think that there's like this magic, let's say, number or a number of customers, or if you are a service that has like, we have one, let's say that's like a bit of a, it serves a lot of patients, right? So they're like, is it number of patients? Is it revenue? And it's actually not even your growth, it is your rate of growth. That is the magic. And that actually is, that's the one thing that's across the board. In like we've invested in online gaming, we've invested in a company that has done that actually competes with SpaceX. Speaking of like the current news, when IPO 2 years ago, so like we've done satellites, we've done digital health, we've done crazy stuff. Every single one thing that threads all those companies together is that one metric. It's not the growth, it's not the revenue, it's the rate of growth. Month over month, year over year, quarter over quarter, depends how long you've been doing this. So that's actually the second most important thing, right? So the first is what is your product market fit and the size of that addressable market? That determines the type of check you're going to get, the type of VC you're going to get. Um, the bigger the market, the kind of the larger, more general VC you can attack, the smaller the market, the more specialized niche VC you're going to get. And then the rate of growth. Those are the two big things that we're looking at. So we don't focus, let's say, on devices and things that need FDA approval. Other VCs do. It's just something that we don't look at. We don't have mostly because we don't have the specialization or the expertise to do that. We don't really look at also like drug discovery and things like that. I said other VCs, other folks do. Again, that's more niche VCs or stuff like that. But again, it's that rate of growth or that rate of really just the rate of growth. So I'll stop there. Hopefully that addresses your question.
Yeah, absolutely. Thank you. Maybe Jonathan, I could ask you the next question. I know I should let you kind of. I don't mean to speak for you in describing Kavi, but I think it's a very interesting organization because you're kind of as kind of a solution accelerator, backed by a healthcare institution. And for those who don't yet know whether they should be chasing, institutional venture capital or strategic capital or non-dilutive funding, how do you help them figure out which capital is the right capital at their stage? And also any kind of add-on, by the way, you want to or agreement or disagreement or anything like that with maybe what Stephen put forward would be great here too.
For sure. Yeah. Thanks, Brian. So yeah, like you mentioned, John Suckling, I'm the Director of Programs and Strategy at the Center for Aging and Brain Health Innovation, which is CABI. And so we're based in Toronto, and we used to call ourselves kind of a niche funder in that aging and age tech was kind of considered a niche space. But over the 10 years that we've been active in investing, it's become kind of more mainstream, and there's probably fewer and fewer, if any, remaining digital health or other types of health tech companies that wouldn't have some kind of an interplay with the aging population, depending on the framing and the use case. And so, like Brian mentioned, we offer different types of funding, both ones that are, backed by our healthcare partner and on the nonprofit side. So we do grant funding as well as dilutive funding and investment. And so for founders, I think really it's, different stages are going to be optimized for different types of funding. And often in, our space, as well as the case with a lot of grant funding, it's milestone based, right? So for earlier stage companies that are trying to perhaps validate their technology, get it adopted and utilized in a particular use case or a particular care setting, that can be great, times to have a grant fund available that funds that exact milestone. Where it gets tricky is trying to raise a lot once you're kind of past that de-risking stage and you've gotten some implementation. You might be looking to more flexible funding, where VC funding can come in and offer a little bit more capital, probably at a time when you're experiencing a little bit more rapid growth. You don't want to be bound by necessarily the milestones that a lot of grant funding comes to kind of an attachment with. And a lot of the time you're going to be reporting on, specific milestones, and it's kind of released in tranches. So there's a lot more of an admin requirement to keep in good standing with your grantor, because a lot of that comes from, the nonprofit space as well. And so I would say, as we have kind of three different programs, the earliest stage being Ignite, which is funding, of the non-dilutive type, and that's mostly for de-risking future investment. And then we have our Fuel and Amplify programs, which are larger amounts of capital, in an investment mechanic, but meant to help really expand upon the growth that, once a company's already found that product market fit. So it really just depends on the milestones and where the company is at, what type of funding they should be pursuing.
Great. Thanks. To you, Darren. I'm really interested to know, since you advise on digital health and medicine issues, key issues like coverage and payment, when you take on a digital health startup as a client, what's the thing you most often see them, maybe too much, maybe myopically focused on, or outright missing, or maybe some exemplars that you might have seen, if you want to go positive.
Sure, you bet. No, anybody who knows me knows that I'm a nattering nabob of negativism. So, you can't get a bigger cynic than me. But first and foremost, thank you, and thanks to CHI for bringing this together, and for having me on the call. And I think Stephen hit upon something very important, which is that where he doesn't, or his fund doesn't really necessarily focus on devices, right? He mentioned that. My area is definitely devices. I work mostly in the regulated space, and that is something that, comes by way of definition, really based on what the device's intended use is. And even though in this wonderful world of digital, where we now have, things that formerly years ago, say 10 years ago or so, the entire device, the hardware and the software would just be deemed a medical device. We've been able to parse things away from that through lots of different guidances and lots of declarations from the Food and Drug Administration, and their over, whelming, I would say, in a way, want and ability to really get out there and embrace digital, talk about digital, even create a digital health center of excellence, et cetera. And, we've been able to now really distinguish between general purpose platforms that aren't regulated at all, and then, of course, device functionality. So, those that come to me by way of having meandered, unfortunately, in this space. And some have meandered in the right way, some have not. And it's really a tale of two different companies, and I'll put them all together in these two different buckets. Those who have done their homework the right way, who really are, very understanding of their, place and category, and even risk profile and classification, understand the FDA, have begun to do the arduous work of, trying to accomplish the general controls, which include the good manufacturing practices and quality systems regulations, have begun to really amass evidence really separately, have discussed their thing with an IRB, or begun to consult people that are familiar with that process, have explored how and who is going to eventually pay for their thing, whether it be, hardware, whether it be software, a combination of both, wherever it fits within the workflow of an organization, or a tool that is just, singularly used by a patient, really understand, where it fits in, within the landscape of, hospital versus, physician service versus practice expense, et cetera, really have an understanding of, at least cursory of what coding looks like, whether it be HCPCS or CPT, and know how uncontrollable and really difficult it is to establish valuation for their thing and then achieve, the holy grail of coverage, pricing, and payment, right? That's one bucket of company. And then you've got a second bucket, which is those who play fast and loose. And I don't really need to get into the nuances of that, but half of those companies aren't necessarily a medical device because they don't seem to think that they are, and yet want all the benefits of being a device, which includes all the stuff on the back end, right? Getting a code and, understanding valuation and then being able to achieve the Holy Grail. But in my regulated place, there is no place for that part of the equation, really. There are some efforts underway, particularly in this administration, which has really begun to have that dialogue of, should we pay for some things that aren't even a device per se? That was a question actually that was posited in last year's fee schedule. But the reality is that those types of things aren't really paid for, and at least not in Medicare Part B. Might be in other areas of the Medicare landscape. So for me, the question that you posited is a really important one. Number one, just to level set my inclusion in this wonderful panel is, I focus on the devices. I really focus on those things that are regulated, whether they be low risk, medium risk, or high risk. And from there, all things flow because really the FDA is where it begins, for the landscape that I deal with.
Mhm. Great. Well, just thinking about the kind of the status of the market kind of writ large. What do you all? This is just kind of a jump ball question to all, but what does kind of a the most fundable kind of digital health company look like today versus maybe 5 or more years ago? And I really, in other words, are there any kind of notable shifts? I think we started to pull on this thread just a little bit earlier, but are there any notable shifts that you're seeing in the quality, the type of digital health ideas, whether in, for example, age tech or others?
I can kind of kick things
Yeah.
off because I think it's kind of a unique angle when you think about age tech and 5 years ago, given that we were in, the kind of midst of the COVID experience, and there was a real societal, focus all of a sudden brought to, thinking about older adults and certain health priorities, and also just making health digital. There was a lot more receptivity for getting pilots. When there was kind of this urgency. And I think that the funding environment, reflected that people were able to, secure a lot more um, opportunity, get their foot in the door with a really good pitch deck. I don't think you can quite do that anymore. I think you need to have, operational data. You need to have really good relationships with your buyers and understand their needs and pain points. I don't think that we're in the same kind of risk-taking space that we are right now in terms of adoption, because we don't feel that we need to, even though, again, on the aging side, 1 in 5 people is now over the age of 65 in Canada, and I think it's pretty close to that in the US. So there's still a need, but there's less of a recognized need. So I think that, in terms of what we're seeing, obviously everyone has AI in their pitch deck. Everyone has some sort of proprietary IP that they're claiming, relies upon AI and different systems. But I'd say, what we're seeing, the more, successful ventures that are, coming in front of our desk, doing well is they're spending a lot more time with end users and operators, understanding what their pain points are and framing their technologies in a way that it addresses those pain points. And an example of that, rather than a technology that says we support caregivers, we address caregiver support. That's a noble cause, right? We should all want to support caregivers, but reframing that is to say, one of the largest costs to an employer is sick days, and one of the largest, audiences that are taking sick days are people who are caring for elderly parents. And so, starting with the framing of we help, companies recover more costs from sick days or reduce the incidence of sick days rather than we're a caregiver support technology. I think the framing of that and then speaking the language of the buyer when you're doing that and then understanding what their decision points are when you're getting into kind of a pilot study and framing it in the same language is part of what's changed in the last 5 years, and that's what we look for when we're making investments in 2026.
I can sure add to what John said is, thinking through like the trends you see in investment cycles is you always see this pulling in from the consumer side of things into a market. You might have heard a phrase, oh, I don't even remember, I'm dating myself, maybe 15 years ago, the consumerization of IT. This was back a million years ago when people were bringing their iPhones to work. And then all of us VCs had to invest in products that looked like the iPhone, which don't get me wrong, it was great because, enterprise software sucked back then, right? I'm going to say 5 years ago, that was the consumerization of digital health. And you started seeing a lot of like maybe consumer focus to the digital health side of things. I remember like CES had this like ginormous wellness side of things. And I think what we're seeing now is more outcome based. And I think maybe because, maybe Medicare is actually starting to slowly, glacially move in that direction, like look at outcome based. I think the industry is moving in that direction, maybe kicking and screaming. But I do think that the funding cycle, we tend to maybe move a little faster, the financial side of things. I do think that now you're starting to see the startup environment move more towards outcome based. Just thinking of the firms, the companies, the startups in front of me, almost none of them are in that glitzier, like consumer-based side of things, and more of them are patient-based and outcome-based. And the pitch deck, sure, they're sprinkled with AI. Don't get me wrong. Oh my God, like AI-based this, AI-based that, sure, right? That's just to goose their valuations. But when you look under the hood, it's all about the outcomes, right? So the patient outcomes really is. I think we've made a complete shift. And again, the founders are really just chasing or reacting to where the market is moving, and I think that's the case, right? So that the big thing, of course, is once you get past the glitz of AI and the pitch deck, and of course, I mean, don't get me wrong. I mean, a lot of the companies are using AI, which is pretty interesting. Specifically, there's some rules that have changed recently where you can use things like AI agents for phone calls where you weren't 2 or 3 years ago, and that's been game changing for a lot of companies that have been in front of us, right? To let's say onboard a patient to your system, right? You can now do a robocall like very legally, and if you follow certain rules, things like that. That said, it's patient based and outcome based, more outcome based versus maybe more consumer based products. Because I think founders were maybe looking at the scale of the consumer market, and I think now they've drifted back and saying, "Oh, wait a second, we like the stickiness of conquering that." The patient market, whether it's insurance companies, whether it's Medicare, things like that, hospitals or clinics, things like that.
Very interesting. So,
Yeah.
go ahead.
Sorry, yeah, sorry, Brian. I was just gonna say, man, thinking back, to what Jonathan said. I mean, the public health emergency was like a really, really big deal, right? So, prior to 2020, I don't remember really what the digital health funding was, and typically where I go to for that kind of information is Rock Health. But I do remember looking at this probably in the last couple of months, and it was like 2020 was 14 billion, I believe, and then 2021 like doubled, and then 2022 it went back down to near 2020 figures, and then it started to go down. And now for 2025, we're back around 14 billion or something. And that's obviously not just medical, that's digital health. So it includes things that are non-medical as well. But you look at something like that peak in the valley. Obviously, that valley, there were a lot of things that were learned in that valley, and there was also a lot of pullback from medical organizations, particularly on the device side, of what exactly they were going to be rolling out, and some of the euphoria over being able to do things remotely. It wasn't so easy. It was clunky. The reimbursement wasn't necessarily great, even though we had codes, et cetera, et cetera. So when I think of fundable, I always think of, in the heat of the public health emergency, I think that if you actually came up with basically anything and said that it was digital medicine, some VC out there would throw money at you. And, now that's harder. And now when people, speak of the big flashy thing that, seems to excite, certain investors, which is AI, now we have, at least more of an idea of what exactly is artificial intelligence in the medical device space. And you'll note that, the majority of AI, solutions really are imaging. And that continues to be the strong one. To me, the North Star has and continues to be, Dr. Michael Abramoff with IDXDR, Global Diagnostics, and their diabetic retinopathy solution. I mean, that to me is still, but that in and of itself is almost, it's a certain type of derivative imaging because it takes, 3 million to 5 million, scans that have been performed, and it uses that to come up with its, AI infused, diagnostic. But we've gone through so much in the last 5 years that I think to me, what is fundable, and the question that you asked is really what is established and what actually has that evidence that I mentioned before, and what actually, has what, Stephen mentioned, which was that rate of growth. I agree with that point.
Yeah.
Mm,
Before we move on, Brian, just one quick thing is just because what Rob was saying is before COVID, because we all kind of forget, and it was a long, and now also it's a long time ago, right? I mean, we're looking 7 years ago, which in VC terms, that's like a millennia. Um, the digital health companies that were before us were very niche. I mean, like one of the companies we funded that's doing phenomenal now was helping graduate medical students facilitate the match. Right, you don't get much more niche than that, right? And that's just one great example. Another one was facilitating visiting nurses to your home for in between oncology visits, right? Like almost like Uber for nurses in that respect, right? Still also, still around, still doing very well. But again, these are very, very niche SaaS businesses, right? And I think that's probably why you saw that dip pre-COVID, and then all the air was sucked out of the room because of the acute public emergency, right? And everyone, all funding kind of pivoted in that direction for obvious reasons, right? And then I think we, as was explained pretty eloquently by Jonathan, then the funding kind of went in that direction. That's why we saw the consumerization, I think, for a while. And then I think we've now went back to this outcome based. But I think that's where we were before COVID, probably from like the 2015 to 2020 timeframe. It was very niche because before that, and Brian, you heard me say this at nauseum at the fly-in. We had the I'm allowed to say Obamacare, right? Like we had that uncertainty of the Obamacare era where there was no funding for a while because we were waiting for the rules, and then when the rules came, there was like this bucket of funding that just kind of rained down on everything. So like us VCs just like showered funding on literally everything, for a number of years, kind of like the spray and pray, type of thing, and then that all settled out. And then at the tail end of that, it really kind of like what we started seeing that was working was like more the niche things, because that's what was getting the traction, right? And then that rolled into the COVID era, and particularly because the beginning of the first Trump administration, the pullbacks were then sent to was what enabled that. I would actually think the Trump administration was, I hate to say this, the first one was good for a lot of the digital health because it pushed a lot of that to the private sector, or at least for the startups in that respect.
fascinating. Yeah, thank you. Well, I think we've firmly grabbed onto this thread, I think, already, and but there was a good bridge, I thought, from what a couple of you all were saying is how often people say we use AI, and maybe how you distinguish from signal and noise when you hear that. I would I could briefly just say, I realize, just as your humble moderator, though, but just for the, from the advocacy the Connected Health Initiative does, it is a pretty compelling use case. The imaging use case and the diabetic retinopathy use case, specifically IDXDR, that Jaron mentioned, I think was pretty compelling. And remains compelling, and translated into coding and coverage in Medicare even, right? But I don't know, past that use case, are there other healthcare AI use cases where you all are seeing like durable value right now? So I guess it's kind of two questions: cutting through the noise, and maybe what any other leading use cases are, just because we name one, imaging, I guess, right?
I mean, I could definitely say, reference a portfolio company that is, they sign big, we used to beat up on the board, the CEO, go sign big, contracts. And they go in and they go, let's say, get like a Mayo Clinic or like a giant, contract. And let's say if they signed up every patient, they would get, like say, 100, well, not let's say it's $100,000 contract or $250,000 contract, what have you, or $1 million, right? That's if they signed up like 80% of the patients, right, of that particular clinic or that particular hospital group or that practice. The reality is they have to like call each patient and enroll that patient. So what they're doing is they're using AI to enroll that. Now they're using AI to enroll the patient, right? A very
Mhm.
sophisticated AI system that starts with an email, follows up. A lot of times, especially when it's oncology, I just had a parent that went through a cancer treatment. A lot of us have these experiences. It's the adult children that you actually have to contact, not the patient to enroll, right? So a lot of times you're not even contacting the patient. So AI has to, AI figures this out, whether it's doing automated, whether it's an email campaign, whether it's, AI robo phone calls, whether it's an email that then gets answered, then gets routed to a human, all that type of stuff that wasn't really easy to do or wasn't even possible, before the advent of AI. So that is one use case.
Right.
They've both increased the amount of enrollments when they've gone to these large contracts and decreased the cost per patient of enrollment, which is it was game changing for the company, both financially and of course with patient outcomes, right? So when they walk up to these contracts, if it's a clinic or a hospital or what have you, or a practice that has 1,000, that has 1,000 patients, they used to maybe only convert. I mean, they should be theoretically, both the customer and the company want to convert all 1,000, right? Because it's a service that Medicare reimburses. So it's a cost, it doesn't cost the clinic anything. And of course, then my company gets all the, all of that, all that business. So everyone wins, and the patients, of course, get the service, right? So literally all three sides of this equation win. And they would only usually convert about 40 to 50%. Now they're converting 60 to 70%, and the cost per patient is down drastically. So, I think, that is where AI has been a game changer and is directly affecting the outcomes.
Great.
No.
So, whew, man, AI. All right. So, to me, when I think of AI in the medical device space, outside of imaging, right? There are other examples, some of which we even used for the CPT Appendix S, which, by the way, for those that are on the call, and at the risk of sounding like a broken record, I'm also an advisor to the American Medical Association. I've been on their Digital Medicine Payment Advisory Group from the beginning. That is the group that was tasked with creating a number of digital medicine codes, including remote therapeutic monitoring, remote physiologic monitoring, as well as helping with the diabetic retinopathy codes, et cetera, et cetera. So when I think of examples, fractional flow reserve, for example, that was one of the examples used in Appendix S. Appendix S is a taxonomy that we created for artificial intelligence. Another was an ECG device, which is, analysis of, that type of a reading from a digital waveform, yet another example of an AI product. But, the place that I think we are really going to see, some big advancements is just what I like to call the better mousetrap. There are so many, examples of things that were made out of hardware or that can only happen, for example, in an office. And now you're able to, minimize them or, miniaturize them and do it from anywhere. And that's the part that's really exciting. Even things like a home, cycler that was used for dialysis. You can't compare that to what happens in a dialysis center, clearly, but it's in a way it helps some aspect of that geography, of that demographic to be able to do things, not in a place like a dialysis center. That's really exciting. Like those are the things that, I look at and it's like, wow, this is where we're gonna, go in the future. Another area with AI is, really the removal of, some of the workflow, which, sure, at the end of the day, the person that has the ultimate say in what happens. It's going to be the provider, whether that be a physician or a non-physician provider. But even on things like you see with Doctronics, right, in Utah, they've been able to now remove having to deal with what I'm going to call somewhat of a burden of prescription refills, and really kind of replace what the clinical staff typically is involved in putting these things forward in front of the provider so that the provider can make a decision on these types of refills, or if they have to titrate something or change something. We are now seeing how AI is being used effectively to be to replace that part of it. And that's not a replacement of the physician or the provider, but it's basically clinical staff working under the general supervision of the provider, which is being removed. So it's not really, now it's really AI working under the general supervision of the provider. So that's where I go with my mind of AI. But something like Doctronic, that's not a medical device. At least it has not been deemed so yet. Really the area of oversight for what they are doing is a state medical board. And I'm not so sure that medical boards know how to deal with this from, a public policy perspective.
Yeah, I believe in an entity that the Connected Health Initiative actually interacts with in kind, and they're great to work with, but is the Federation of State Medical Boards. And I believe they've just launched a new effort to tackle the exact issue that you're describing. So really at the forefront there, trying to deal with it. But um, I guess I did wonder if Stephen raised something earlier that is important too. I guess it's kind of it's just that the that I thought might be worth pulling another. I keep saying pull on a thread, but another thread worth briefly pulling on for people, and that was the kind of the quantity versus quality, or the advancing from today's fee for service world to a value based care world, and I think you had even briefly mentioned how in the Medicare system there's a new push, new effort to explore that area. And I was just curious if you all had any kind of perspectives on that issue generally, about about whether I guess whether there's more or the real, or however you want to frame it, opportunity as far as value-based care, where the incentives are outcome aligned, if you want to put it that way, and even any how some of these programs, such as the advancing chronic care with effective scalable solutions, or access model, which the Centers for Medicare and Medicaid Services in the U.S. Health and Human Services Department has relatively recently launched. Does anyone have any further kind of thoughts or comments on that?
Yeah, I can maybe start things off. I mean, one of the, I think with aging and our space, like reactive medicine has kind of been the way that aging has been viewed for such a long time, right? And someone gets sick, or they develop a chronic condition or some sort of a neurodegenerative symptom. They go in, they get tested, and then it's, fragmented from that point. It's extremely expensive. And so I think that the closer you are to kind of the edge of that, healthcare waterfall, where you're starting to, increase your utilization of the health system, and you're in medical environments more and more, the more opportunity. And so we're absolutely looking for technologies and companies that are making this more of an upstream approach, when it comes to considering, aging doesn't start at 65, right? Aging starts when you're born. And it's something that I think is really critical to have kind of that broader perspective on. And so, some of the ways that we've seen that start to manifest, things like, remote monitoring, using a lot of the times, using AI, and being able to pull more data points, not just from manual input, leaning on, the healthcare teams to input more and more things into dashboards, but just pulling directly from a sensor technology, a radar technology, a wearable technology, right? And having those multiple different points kind of come together. So aging in place is a huge area where we're seeing a lot of that. as well as, kind of on the care coordination and navigation side of things. It's, at the stage where someone may need to, consider what available health, resources they should be looking at to support a loved one with a new diagnosis. Not overwhelming them and having, solutions that can pinpoint the right resources in their area and help them kind of make sense of all of that doesn't necessarily, have a fee for service label on it at the upfront stage. And it's going to be something that it gets packaged as more of kind of a wellness technology, and that also kind of increases the ease of regulatory adoption and approval and bringing some of these technologies in. But it's a really, important area, and everything I think that we're touching and looking at now has to be kind of more a health-based model rather than an illness-based model of technology.
Mm, great. Well,
Brian,
oh
I'm
yeah, go
sorry.
ahead.
Yeah, it takes me always a second to unmute. Um, I think that when we talk about value-based care, right, and I think that term means a lot of things to a lot of different people. I always, as a lawyer, always go back and think, well, what is the regulation? What statute is this thing, stemming from, et cetera, et cetera. And it's been a while, but I'd say probably in the last couple of years, whenever I do think of value-based care, I specifically go to a website that CMS has for what they feel value-based care is. And I thought there were only like, I don't know, maybe a handful of programs that fall under that designation. That said, I think it would take an overhaul of the benefit category in order to really change fee for service to value-based care, really. But having said that, CMS does have at its disposal, their ability to do what they feel is in the best interest that's reasonable and necessary, and just move on from that. And something that I thought was really novel is the advanced primary care model, APCM,
Mhm.
which, if you look at APCM, it's not time-based. There's no time designation to those codes. And that to me was a very novel thing that was done because, regardless of all of the different, requirements that are under APCM, at the end of the day, it's intended for, one code was for 0 to 1 chronic conditions, the other code was for 2+ chronic conditions, and the last code was for those that fall under qualified Medicare beneficiary status, which means that they are, the destitute of the destitute. And, to me, that idea of care management and really a communication technology based service without having a requirement for the time and intensity of the provider of really qualifying that time. It has to be 20 minutes, it has to be half an hour, it has to be 40, whatever it is. That's not there. So that's a big deal. That to me begins to get into, more of, okay, so what is the actual purpose of of this service, right? And
Mhm.
the purpose is to actually, really effectuate change. That I thought was a novel thing, and I think it's a great thing.
Mhm. Great. Well, I think I see a question or two has been asked in the Q&A, so that's awesome. I appreciate everybody's engagement, and I have one in the queue here, but also just uh, I guess I switching up a couple of questions as I was thinking about them, but as we've talked, if I could flip it back, question back your way, Jaron, is when for some of these startups companies who hear get a CPT code as their answer to absolutely everything, what is the more nuanced reality we were, I think, alluding to earlier a little bit about building a reimbursement strategy these days?
Yeah, so that's funny that you ask it that way, and I'll say it this way, right? I have a ton of companies that always come to me and they're like, how do I get reimbursement? And really what they're asking is, how can you give me an understanding of the journey towards reimbursement and what does that actually look like step by step? And that starts with, clearance of their device or a de novo, designation, and then we get into, building the evidence, which goes beyond just safety and efficacy. It's actually evidence that your thing actually does work. What is it, what is the intended outcome? Well, okay, does it accomplish that given the demographic that your thing is supposed to work on? Is it for juvenile? Is it for older American? What is it for? Right. And then we can get into, okay, is there a descriptive code for, whichever, most appropriate model of payment model does it fall under? And a lot has to do with how you make it available. Is it something that's, durable and medical and can be reused? Or is it something that, is really a practice expense incurred by the provider on behalf of the patient and that they're going to provision it to the patient so that they can, really do better healthcare? It makes a difference, right? It's a really big deal, right? And then we get into valuation, and then we get into coverage, and then we get into pricing, and then eventually you get into the payment, right? So it's a huge journey. And when I get these nascent little companies and they come to me saying, hey, how do I get reimbursement for my thing? Then the follow-up is that they think their thing is so novel that all of those programs and that framework under that I just kind of rattled off, they think that somehow the framework is going to adapt itself to their thing because it's just so great. And then the question that I always ask is, all right, so what's your evidence? And they're like, well, we have this small study that we did with like, my grandma's, community, resource center. That's not really the kind of evidence that we need. We need, an N of many, and an RCT would be awesome. And I realize that that's not probably going to be the case. They cost a ton of money and it takes forever. But, you got to, do something that's somewhere in between Grandma Civic Community Association and an RCT. And it would be great if you can get it, published and get it peer reviewed. Even if it's in the Akron Gazette of Cardiology, at least it's something. Sure, I would love NEJM, I'd love JAMA, but we might not get there. But that's how you build evidence, right? And it's and we realize you don't have a lot of money. And there's actually a way to create codes for new and emerging technology to focus on things like what I'm mentioning, without having NEJM and JAMA and all that. There are steps, but that's the key, right? They've got to learn that the framework is not going to, become malleable and accommodate your particular product. You have to do that for your product based on what the business interest is and how it can get paid for and how it can get disseminated. And from there, you have to go through all the steps. And that goes back to the first question when I answer that, companies come to me that have done their homework, and then others come to me that, are playing fast and loose. And I mean that because there are so many companies out there right now that are claiming that they're a medical device, yet they're hiding under, the moniker of being under enforcement discretion, which is not the reason why FDA created enforcement discretion. It was to tell you you're not being regulated, go away. Not You're not being regulated, go away, but you can go and tell all these providers that you're actually a medical device and you can be used as a reasonable and necessary thing to get payment. That's not what we, set out to create when we created the codes, we being the DIMPAG and, CPT, having undergone and undertaken that whole thing. So yeah, so this is it's a very broad question that you're asking. I hope I was able to answer some of that.
Yeah, no, that helps immensely. I mean, for you, Stephen and Jonathan, if you want, hearing that, how do you all think
I was gonna
about?
say Steven's hand is up, and I think
Yeah.
I
Oh,
pissed
it
him
is.
off.
Oh,
I just want to add to that is
yeah.
I could tell you about what happens downstream for that is once the company has been successful and then now they've got the code and they're already, so now the startup is, yay, right? Like success, they've gone to the promised land. Well, it's not all, fun and roses at that point too, because now, I mean, I'll tell you a story, and I've heard this is not isolated to one company. So you see a CEO coming back to you, whether you're the VC or you're the VC on the board, doesn't really matter. And they talk about losing a fairly large account or a small account or just a significant account in general. It doesn't have to be large or small. They're just significant. And then you ask them why. Why did this customer churn? And they say, well, they said we were too expensive. And then you go, but aren't you 100% reimbursable for that customer? They go, yes. And then they said, well, then why did they cancel? You're free for them. And they go, well, we didn't do a good enough job, like explaining to them, and I go, no, you did not do a good enough job demonstrating your value to the customer and the outcome to the patient because, truly you did at the pitch. But then when you went downstream into administration land and downstream into like implementation land, the patient was probably happy, right? And the, administrator who brought you in was probably happy, but like somewhere in that middle layer, wasn't happy. And since you can't bill on, let's say, Medicare's behalf or whoever, whatever, is administrating this code, because that's illegal, right? To prevent fraud, you drop the ball in getting that, like all the way across in that organization and demonstrating that value, right? Because you just then focused, right, on one side of that equation, whether you focused on it for just the patient, not the organization, or maybe you focused on it just for the organization and not the patient. So the founders usually get to that finish line, and I say they collapse, right? Because in fairness, because it's exhausting to get that far, right? But then they just forget that, like, this is like all enterprise sales, by the way, not just in digital health. I mean, if this was a different webinar, I could go off and say how this is analogous to just, you made a big sale to like Procter and Gamble, and then I guess the exact same problem, just with very different, very different parameters, right? When you have a usage-based kind of enterprise contract, but that is, just because you actually got those codes doesn't actually mean that it will be sustainable. You actually have to continue doing that work downstream as well. I've seen this so many times that it like drives me insane. So yeah, I had to add that in.
That's great. No, thank you. Yeah. Yeah. I mean, that's it. You pretty much got it kind of, I think, what the next question I was going to ask was. I don't want to ignore the question that we did get in the Q&A function here. For anyone who wants to answer this question, sorry. There we go. Is there such a thing as a saturated space in health tech or digital health markets today, even in the private sector? That's an interesting question. Does anyone?
It is an interesting question, and I like it. I mean, I'd say there's certainly crowded markets and there's competitive markets, but that doesn't always or really ever mean that there's no opportunity left. I think that just recognizing that in highly competitive spaces, you're going to be dealing with buyers who've seen a lot of similar pitches, and you're going to be dealing with a really, difficult environment to make meaningful differentiation. And so that's where things like having evidence and even, anecdotal evidence, if you're not able to make a broad claim yet, can help get a foot in the door, just to say, we have some stories, even if it's human impact, that can help people to stand out. People remember those kinds of stories, especially if it's an early on. But yeah, things, generic telehealth, scribe tools are extremely
Yeah.
busy spaces where there's a lot of activity. And so I think, having to make the case there that you stand out, not just on the basis of your technology, but a lot of the time on the basis of your team, I think is a good way to start, and to talk about kind of the expertise that you and your group brings, and how that can't be replicated can be something that's compelling to people when you're dealing with a very busy and crowded space. So yeah, it's a good question.
Yeah, I tend to agree. All that back office stuff or competitors to Epic, or like data pipes to and from Epic, or I can't tell you how many Epic killers I've seen, or yeah, that kind of stuff. Like you've got to have the more patient outcomes is where it's at. Or the remnants of the previous cycle that I described, right? Like it is crowded now if you're going to go in and build a corporate wellness facilitator. Like that has been done. And like the winners are kind of already, they have their head start, right? They were funded 5 years ago, right? That type of a thing, right? So that space is crowded because, that funding cycle has already ended, right? So if you're coming to me with like a mindfulness app or, any type of corporate wellness benefits program, things like that, like that funding cycle's over. Like that's fairly crowded. The consolidation has already begun in that sector, right? Like because the winners are already starting to pull ahead.
Mhm. Great. Well, I know. I think I did want to touch on maybe before we break. Kind of the bucket or the theme of exits, or what success looks like. I mean, what do you all think what are the realistic exit paths in digital health are right now? And Again, maybe this is a little bit of trying to pull out a reflection on how things have shifted or evolved over the last 5 years, or more, or some different time increment. But uh, just thought I'd throw that one out there.
Yeah. Go
I'll
ahead.
take
Go
a
ahead.
quick. Oh, sure. Yeah. I mean, I'll be quick because there's few. I mean, obviously, the IPO market is scarce, and not because of, let's say, the previous administration, as some of the restrictions that were on. It really just goes way back to Sarbanes-Oxley, right? So Sarbanes-Oxley, back I think it's 2002, right? It's just made it harder and harder for startups to kind of get to that bar of an IPO. So public markets seem to be cut off. So M&A is the typical route, or private equity. So we've seen a ton of private equity, typically like a roll-up strategy where you have a digital health company that is very successful. They have something that's rather unique, or they're just a market leader of very few. There's three dominant players, and a private equity will go get that dominant player and then build an ecosystem around it. So not necessarily build, maybe they're not buying the three competitors, they're buying one of the three competitors, and then capitalize that one company, and then to then acquire other companies that are orthogonal to that company, or complementary to that company, right? So then they would build an ecosystem around that company to make it a larger kind of ecosystem of companies, right? So then it would be a horizontal play. That's actually been popular over the years, and that's the one potential nice, I guess. Any private equity people in the room are going to bash private equity because they're really bad with hospitals and things like that. But that's actually the one positive contribution maybe private equity's made to the healthcare system in the United States, because that actually strategy does bring benefit to everybody. I mean, obviously it brings a lot to them, but it does actually create a good it creates a good exit for the investors and the founders, and it creates incentives for other founders to go create businesses. But more importantly, a lot of those smaller players that either wouldn't have had an exit or might have died become part of this larger ship, so to speak, and it sails down the system, and then it becomes a compelling, like a hospital system or a large enterprise. Actually, it becomes compelling as a customer as well because it's a much larger entity.
Thoughts? Were you going to
Brian,
say? Yeah.
yeah, I
Go
was gonna
ahead.
say in closing, I mean, I'm not sure this will get to answer your actual question, but AMA has been able to, which AMA is the House of Medicine, as I like to refer to it. One of its organizations is CPT, the Current Procedural Terminology panel, and the panel convenes once every 3 months or 4 months a year, and decides, the future of coding. And they'll amend existing codes, they'll delete existing codes, they'll create new codes. And, having been involved in this process now for the past oh my gosh, I can't believe it, 11 years. AI codes and, codes for digital medicine really never, proposals would never show up. And now they show up dozens at a time. And that doesn't mean that they all end up eventually becoming codes. Many get withdrawn, many get rejected, et cetera. But AMA has really done a much better job in trying to help this area of nascent technology developers understand where AI is going to fit in the taxonomy. The taxonomy is really composed of 10,000 different codes. These are CPT codes, and they account for medical procedures, medical services, practice expenses, which include medical equipment, clinical staff time, disposable medical supplies, et cetera. So, this tool, and I referred to it earlier, Appendix S, which was created. I was part of the group that created the original. It recently was amended. It grew up and went beyond, my area of work, and now has been, taken on by the panel, and it's been updated. The update, I think, is going to get posted sometime soon. But it created three categorical areas for artificial intelligence, which include assistive, augmentative, and autonomous. And within autonomous, there are three levels of autonomy. Now, I don't have the time to get into exactly every single one of these, but for those out there that are creating, these innovations, spend time to look at this. If you're really involved in provider services, really Medicare Part B, understand the taxonomy. It's there to help you. And be proactively involved when CPT goes to try to do its next step, which is to create a part of the code set, not category one, not two, or category three, but a part that's going to be really devoted to clinically meaningful algorithms, and it's called the CMAA. And, that's going to be a big deal. So, be involved, pay attention. You can't then say, well, they created this thing which, is not helpful if you actually did participate. And they do listen. So please get involved. Please pay attention.
Right. Don't have it done to you. Be part of it.
Bingo.
I
And
couldn't agree
use
more.
organizations like CHI, which are absolutely very proactively involved. Morgan Reed, the executive director of ACT, the parent company, is involved. He's a DIMPACT member, as am I. Brian attends many of these meetings. He's very much involved. That's what CHI is here for.
Right. Well, I realize we're at time. I had more questions. I'm glad we got a couple of questions. Thanks to you, Stephen, for answering that one in the Q&A function. But we had one I got to ask too. Really appreciate everybody tuning in. And unfortunately, we're at time. But Stephen, Jonathan, Robert, thank you. Thank you very much. And for everyone watching, we'll be posting this recording, and we'll be sure to send follow-up resources, including a number of the ones mentioned. We'd love to hear from you about any of the questions or issues or opportunities that you're seeing out there as we all try to pull the whole digital health community together to advance the ball, whether it's some small incremental step that moves us a little bit closer towards more enablements or putting a framework in place to responsibly develop these the cutting edge digital health tools, or something broad and sweeping or anything in between. I think you'll I hope you'll join us in pursuing those changes. So anyway, with that, thanks everyone. Really appreciate your time once again, and have a good day.
Thanks, Brian. Thanks,
Bye, all.
everybody. Thanks, Stephen.
Thanks a
John.
lot. Yeah.
Take care,
Thank
guys.
you, everybody. Take care.